Hi, this is Dr. Janikaram Shilpi Bhatia Sharma from India, and you're going to see a case of endoscopic nasopharyngectomy. 35-year-old female, present with history of nasal obstruction and epistaxis on the right side. Patient had two lesions, inverted papilloma of the maxillary sinus and adenoid cystic carcinoma of the nasopharynx. You can see that the carotid was involved. The laceral part, you can see very clearly the laceral part and early petrous part was involved, and you can see that doing a diagnostic nasal endoscopy, patient had epistaxis. This was a choanal banking effect. You can see the mucus which was banked up by the lesion. You can see the lesion very clearly. That was an adenoid cystic carcinoma. Biopsy was taken, proven to be an adenoid cystic. You can see that this was the lesion, and the patient also had a problem in the maxillary sinus, an inverted papilloma, so we had to tackle both the lesions at the same time. The first step was an inferior turbinate resection. So basically we'll plan for a four-handed technique, and that was actually a posterior septectomy plan. You can see the inverted papilloma there on that was a separate lesion and we had to take it off. So we planned for an endoscopic modified Denkers also. So that, and now we are doing a posterior septectomy away, 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 and create a big posterior septectomy for binostril approach. And you can see that we have done that. The left inferior turbinate is seen, left middle turbinate seen, and now we have done a modified endoscopic Denker, removed the inverted papilloma, and you are seeing the posterior wall of the maxillary sinus. What we are doing now is to take off the posterior wall of the maxillary sinus with a cutting burr. That's a 3 mm cutting burr, and we are taking this lesion was extending right till the infratemporal fossa, and beyond the level of the eustachian tube. Rotatable scissors, 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 rotatable scissors to take off the periosteum. And you can see how beautifully the periosteum is being cut off and elevated from the posterior wall of the maxillary sinus. And you can see now the artery coming into view. That is the imax, very beautifully seen, dividing into the descending palatine and the sphenopalatine. Now before we ligate this artery, we will now delineate the V2, that's the V2, very clearly delineated, and also the pterygopalatine ganglion there, suspended from the V2, very clearly seen there. Yes, that is the pterygopalatine ganglion. And once we delineate that, we are now clipping off the internal maxillary artery. Two clips are being put there, and then the contents of the pterygopalatine fossa will be pushed away laterally. Once we do that, we visualize the pterygoid wedge, and that is actually the drilling of the pterygoid wedge, the medial and the lateral pterygoid plates and the pterygoid wedge. Once we do that, we can see that the growth will be there posterior to it, as we can see here. So it was a very huge, extensive mass lesion involving the nasopharynx, going till the level of the soft palate inferiorly. We are now using cautery, and we are trying to completely go around the mass, take off that mass, and then we will be debriding away the longest cavitous muscle as well. Now we are going towards the infratemporal fossa, and that's the infratemporal surface of greater ring of sphenoid. You can see the growth going there right posteriorly, and we are now, this is the way we gain access. We completely gain access and then only drill. In fact, that is the basi-occiput basi-sphenoid. We are drilling it off, and once we do that, we can see the growth right there, and this part of the growth is abutting the level of the carotid artery. You can see that now we are gently elevating that growth there, right inside the sphenoid sinus. It was also going into the sphenoid sinus. We are now taking it off from the sphenoid sinus. A small part of the growth was there inside the sphenoid sinus, and that was removed there. And once we do that, we have to take off the growth from the level of the lateral carotid. And if we have to get the growth out of the lateral carotid and the petrous, we'll have to get a proximal and a distal control. So what we did was we drilled away the carotid canal, the paraclival carotid. You can see that we are now getting a control over the carotid by elevating the bone over the carotid canal. That's the paraclival carotid. So we are now completely exposing the paraclival carotid. And we had already got a neck control. So that is the Doppler. Now you can see that the growth was sitting right over the region of the lateral carotid, and now we are trying to use a scissors just below the level of the carotid and take off that mass now, and this mass will be removed completely from the infratemporal fossa. This is the infratemporal fossa part of the mass. You can see how beautifully the eustachian tube has been now is being transected. So this is very important. When we transect the eustachian tube, care should be taken not to chop off the parapharyngeal carotid. And now you can see the growth has been completely removed there. That is the Doppler being used again to check where the position of the carotid is. Now we clearly have an idea, and once we do that, we are now going to remove this growth from over the lateral and the petrous carotid. You can see now that we are using a Rosen's elevator very gently over the growth and parallel to the carotid. That's very important. We should understand the anatomy of the carotid. That's the V3. We are cutting off the V3, which is in front of the carotid. That is, and we will be sending it separately for frozen section. You can see the branches of the V3 very clearly there. And that is actually the carotid now coming into view. Yes, that is the carotid. And you can see that the growth is sitting right over the endosteal layer and gently being removed there. Utmost care should be taken not to go at right angles to the carotid. That is very important. We should understand the anatomy of the carotid. Now you see how beautifully the growth is coming out, and that is the V3 in front. And now that is the growth over the paraclival carotid, completely removed there. And this patient will be subjected to radiation, so we will cover this part of the carotid with mucosa. We have now done around 13 nasopharyngectomies. You can see a complete clearance achieved. The whole fossa is clear. There is no bleeding at all. We give warm saline irrigation, and then we use Surgiflow for hemostasis, then Surgicel, and this is the post-op. You can see 100% clearance of the tumor. Thank you very much.